Okay, so good evening, everybody. Today I'm going to talk about the various surgical technique of bleb needling with injection mitomycin C. So uh, as my previous speaker talked about the pre-op workup, how the pre-op workup and the post-operative management is equally important, uh, equally management for the successful trabeculectomy. But anyway, anyhow, after doing our best effort of the trabeculectomy, somehow some patients really they need the further need of the surgical intervention. So when we all our efforts to survive bleb is fail, ultimately we need the surgical intervention. This is called the bleb needling. So aim of our bleb needling to bleb revision to re-establish the fistula from the anterior chamber to the subconjunctival bleb, where the aqueous humor may be reabsorbed. So how to recognizing failing bleb? I think it nicely described by the Dr. Shamila. So we see the less diffuse bleb, vascular and flat and opalescent. So what is the exact cause of the trabeculectomy failure? Is subconjunctival fibrosis and subterranean encapsulation. So we come to know where is the bleb is going to fail, either at the level of the bleb capsule. So there is a fusion of the episclera or subterranean tissue at the subconjunctival episcleral area. Sometimes we get the gray membrane here. And second side, most common side is skull flap, either fusion of the skull flap to the underlying sclera, and sometimes the closure of the ostium. Ostium may be closed by the fibrin, by the pigment epithelium, sometimes vitreous, sometimes cortex, and sometimes adjustment fold also. So now come to know when to do beadling, when to do the bleb needling. When our the various like the distal massage, suturolysis, and aquasuppressant, and the antimetabolite like injection FU or 5-FU, all are failed to revive the bleb, then the surgical intervention needling is the next step to maintain the functioning bleb. So what are the indication of the bleb? When episcleral scarring are responsive to conservative management and excessive scarring or encapsulation of bleb, or there is a elevated IOP with deep anterior chamber. In this condition, we need to do the bleb needling. So these are the when to do the bleb needling after the surgery. So initial reports have suggested the short interval between the initial surgery and needling associated with good success. And needling revision performed less than 4 months from the time of trabeculectomy associated with greater success than those performed later. However, the fewer controversial literature is available. Some of the authors have presented good outcome in the late post-operative blood needling. But in our hand, really late post-operative blood needling is not working well. So I think what works in your hand, we should do it. So what is the prerequisite for bleb needling? First of all, check the internal ostium with gonioscopy, and there should be some amount of the bleb elevation should be there. And before the bleb needling, we have to check the conjunctival mobility, where conjunctival mobile around the bleb area, and patients should not be on anticoagulant. Then coming to the bleb needling, the counseling is play a very important role, because again this is the resurgery. Again we are going to do the patient taking the OR or in either an OPD. So we have to talk about the patient risk and benefit of the procedure. Even after the doing the bleb needling, probably he may need the further surgery and he need the further medical treatment. So good informed consent and reassurance to the patient is the key of the before the procedure. Then what the knife you want to use, whatever you want, whatever works in your hand, you can do it. Most commonly use 26 gauge needle, 30 gauge needle, MBR knife. These are the history of the bleb needling. Over the last 30 years, multiple publications have reported needling is a part of the armamentarium of the post-filtering surgery. And these are the study done by the Mardley et al. In 1996. He showed the good success of bleb needling with injection MMC. And what we use all bleb needling with the use of injection MMC and 0.1 ml and 0.04 ml milligram per ml. These are the various antimetabolite has been used. MMC, 5-FU, Avastin, and Lucentis. But these Avastin and Lucentis didn't show much encouraging outcome. Especially nowadays, the MMC, most of the surgeons are using the MMC injections. So the studies have shown the MMC and 5-FU have the good outcome in the bleb needling. And recent report in 2060, we at all showed the needle revision with subconjunctival MMC injection were more effective than the subconjunctival 5FU injection for Blep failure following the triple. However, the recent literature compared by the Harvard University, they didn't find out any difference between the injection 5FU and MMC. So technique of the blood needling, either we can do in slit lamp or in an option theater, depend upon the surgeon choice. Always in my option theater, and I always do in my blood needling in the topical anesthesia. If you are not comfortable, you can do for the peripheral anesthesia. So providing iodine has to be applied before the procedure, and a application of the adrenal swab may help to reduce the intraoperative bleeding. So this is the one of the case of the blood needling, a post-phaco trouble. So before starting that blood needling, just be injecting the injection 0.1 ml of the injection MMC plus 0.1 ml lignocaine, and this 26 gauge needle is bent around the 45 degree. After bending the 45 degree, this needle is introduced 4 to 5 millimeter away from the bleb, and slowly we have to move the needle inside, and we cut parallel, and we follow the contour of the globe. After cutting the subconjunctival fibrosis, we locate the skull flap and go under the skull flap and reach into the anterior chamber. Once you reach the anterior chamber, you can see the softness of the globe. You can feel with your traction switcher, and this is the end point of your blood needling, and AC is formed. Okay, then this is successful blood needling. And this is another case. This is a blood needling that you're doing in the phakic eyes. So in phakic eyes, we have to take the special precaution, as Dr. Sarmala has already shown this video. In this video, actually after giving the injection MMC and lignocaine, just we do the ocular massage. After the ocular massage, we waited for 2 minutes. After waiting 2 minutes, take the clear corneal traction switcher. So it helps in a maneuver of the blood needling. Here the side port is made, and we use the AC maintainer. So AC maintainer is used to helpful throughout the procedure to maintaining the anterior chamber. So this maintaining anterior chamber is very crucial, especially in the phakic eyes. And this is a very thick walled bleb. So take the needle. I am going through the left hand side because I feel this side is more fibrosis, and I'm trying my hard to get out this thick bulb of the bleb, but I'm not able to pierce the exactly, and I'm not able to lock it. Here is my skull flap. So this you can see here white color thick bulb, actually thick valve of the bleb. So after this, I'm here not able to get my skull flap. So after cutting the few strokes, I move into the another side. So I didn't find out my flap. Then again I moved here, and this is the here. Here is somewhere under the here is the flap. So I just move under the flap, and then the bleb is. I got my AC become a little bit shallow, and fluid egress from the anterior chamber, and successful blood needling. So there's what's the advantage of blood needling at slit lamp? This is a outpatient procedure. Okay, this is a very cost effective, no need to take into the OR. A psychological advantage to the patient. Patient is afraid when you ask for go for the blood needling, go for the second surgery, again they have to go to option theater. So most of the patients are afraid of again going to the option theater, and the little inconvenience, and has the less time consuming, because you finish once you are expert in doing the blood needling, you can do in slit lamp very easily within a 5 to 7 minutes. You can finish whole the procedure. So this is a video of the blood needling at slit lamp. So before doing the blood needling, always use the anesthetic drop or anesthetic cotton tip applicator soaked in the topical anesthetic, applied for 2 minutes at the conjunctival side where you want to enter into the bleb. And again, this after the antibiotic drops, and you have to use the providine iodine solution before the blood needling. And this is again the needle is passed 5 to 6 millimeter away from the bleb. In this technique, we should not do the do the conjunctival, we should not remove the conjunctival fibrosis first, because sometimes it is very difficult to get the removing the subconjunctival fibrosis, and this always we are tend to make the buttonhole because we need the extreme cooperation from the patient. Patient has to look down, and most of the patient in the circulum, when we do the patient cooperation a little bit less in compared to the OR. Sorry. Just a minute, yeah. So in this technique, I used to first lift the flap. First lift the flap. Once you lift the flap, so some amount of the aqueous egress from the anterior chamber into the subconjunctival space. So this fluid will going to help us to go for the further subconjunctival fibrosis removal, as is shown in this video. So now fluid is kept, and you can see then the globe becomes soft once this come out. So this is another ab-internal Blep needling. This is a transcorneal needling at the circulum. This is developed by the Dr. Paul Baumberg. So what in this technique, what he used to do, make the 30 gauge needle bend in the jet-shaped manner, and this needle is introduced into the ciliary cornea. Through the ciliary cornea, through the limbus, he is going under the flap. So this flap, and he is removing the subconjunctival fibrosis. Really, I don't have any personal experience by doing it, but somehow he's working with Dr. Paul Baumberg's hand, and really he published recently. He published one paper on this transcorneal needling. Then coming to needling after the tube surgery, especially when the Ahmed ball and crippling ball, we have the encapsulated bleb. So in such scenario, we can try bleb needling in the Ahmed encapsulated valve. Then the repeat needling is a matter of controversy. Some surgeons don't want to repeat it again, but even the another set of surgeons, they say we can do separate incidents. We can do the 3-4 times. We can do the needling. But whenever we want to do the needling again, we have to keep in mind there should be initial improvement from the first needling. If the first needling is successful, or some of the amount of IOP control and the blood morphology change, then only you should go for the second needling. So what are the risk factors for failed needling? It's a pre-op IOP more than 30 mmHg, or the trap with MMC, trabeculectomy without MMC, and this immediate post-operative IOP more than 10 mg, or sometimes if some surgeon feels needling done after the 4 month of trabeculectomy is most likely to fail. But again, this is a controversial issue, because right now lot of surgeons doing the late needling. So post-operative care, the settlem examination and tonometry as well as the sedal set should be performed 30 minutes after the procedures. And after the procedure, topical steroid antibiotics are prescribed for 4 to 6 weeks. There is some complication like hypema, hypotony, blebitis, kissing choroid, and endophthalmitis may occur. So just to conclude, bleb needling can rescue a failing bleb, save patient burden of using multiple anti-glaucoma medication, and repeat surgery. Bleb needling should be considered when bleb fails post-surgery. Needling does not affect the outcome of future surgery. In addition, needling may convert failed bleb into a more diffuse bleb, which reduce the risk of bleb leakage and late endophthalmitis. Thank you very much for listening.